Sorry, guys, I'm gonna have to run multiple computers just so you guys can see up on the screen, but then we're recording on my laptop, so I'm just gonna have to be really coordinated here. Okay. Okay, Jordan, can you see my screen?
Carly, I can see your Teams page. Sorry, it's just nothing's pulled up yet.
Okay. Um,
Now I just see you.
about now?
Yep, I got it.
Right. Let me make this bigger for you guys. We'll zoom in. All right. All right, so we're just going to go down through the questions and I'm going to go over the answers, maybe some of, some questions in here where some of the answers that are incorrect, why they're incorrect, but just going to really do an overview of the test in general. So as questions come up, just please ask. Okay, so question number one, this was one that we played on Neo Jeopardy together on Tuesday, but a baby that's admitted for suspected sepsis, which answer is true? So the big one here is going to be that we are prioritizing blood cultures when we're getting the PIV, then we will administer antibiotics. I feel like most people got this one correct. When admitting a 32-weeker with maternal choreo, what medications are we anticipating? So really looking for our broad spectrum antibiotics here. So that's going to be our AMP and our GENT. Scroll down here. Jordan, can you just make sure that like you're able to see the questions that I'm on, because I'm operating the big screen and the laptop just in case I have an ADHD moment. So then question number 3, your patient is on ampicillin ordered to give at midnight. Where would you expect this medication to be located? Just wanting you guys to know the difference that in an admission, you guys are going to be getting ampicillin stocked on our unit in the Omnicell. And then gentamicin is going to be the one that is made up by pharmacy and sent via tube station. Okay. This is really just med math here. I'm not going to go into the nitty gritty details of it, but you're doing ampicillin medication calculation for a baby that's 3.5 kilos. You'll bring that into your dose of 100 milligrams per kilo. And then overall bringing in that division of concentration of 100 milligrams per ml. And then you should have ended with 3.5 mLs of ampicillin. How to reconstitute AMP. I feel like those that got this question wrong were using the either IM dose of ampicillin, and they were bringing in the concentration of 250 milligrams per ml, or they were doing incorrect rounding. It was a rounding error. So did the medication calculation, but we were also looking for the patient-specific dose. So the other reason people got this question wrong was because you didn't give us the amount that you were pulling for your patient, or it was just the incorrect dose. On admission in our NICU, how is gentamicin administered? So on admission, we give this over 30 minutes on the syringe pump. It's evidence-based practice and proven that we're going to do these antibiotics over time. to make sure that it's at least started by the golden hour. It doesn't need to be finished, but you would give your ampicillin first, and then you would go to your gentamicin next, just to make sure it's started by that golden hour. Okay. So then we're going to scroll down here. So then the next question is going to be how many mLs of fentanyl would you administer for your patient? Again, basic med math. So starting with your weight, bringing in your dose, dividing by that final concentration. For this calculation, you should have ended in 0.46 mLs, always rounding to the 100th place to get the correct answer. Okay. Oh, wait, I'm sorry. Did I miss? Oh, I missed the admission dose and then after admission dose. So the after admission dose is the same, 30 minutes. Some of you guys may have seen that your preceptors were telling you that you do a slow IV push for the admission gentamicin. This has actually been a new evidence-based practice change for our unit in the last year, but something that we covered in the med presentation, administer presentation, and then also in Neo Jeopardy on Tuesday. Any questions about gent? Sorry, I skipped that one. Okay. Then we talked about fentanyl, number 8 with the med math. So then how would you administer a fentanyl bolus? So going over all of the questions, just knowing that like giving it over 30 minutes is going to be way too long. Fentanyl is shorter acting in that sense that if you're giving it over 30 minutes, it's not actually doing that pain management criteria that you want. Pushing it as fast as possible, rapid push. What are the only 2 meds that we rapid push? Epi and adenosine, exactly. Slow IV push over 5 minutes. That is going to be our correct answer. Over 60 minutes, way too long. And if you do look up Neofax, the fentanyl administration, 30 and 60 are way outside of the parameters of, I think that it says 5 to 10. A lot of people run it over the pump. You've probably seen some preceptors slow push, just making sure that you're giving it nice and slow because fentanyl can cause that chest wall rigidity, which is in the next question. What is a possible side effect to monitor when administering fentanyl? So the 3 things we were looking for here are respiratory depression, hypotension, and chest wall rigidity. Hypoglycemia is not one of those answers. So if you got partial credit here, you may have just missed one of these 3 correct answers. All right, question number 11. You call your provider because your patient continues to fight the ventilator and tries to grab the tube. The provider increases the PRN fent and also adds a PRN midazolam, so Versed. What is midazolam used for? So we're really looking for here that it is treating the agitation and decreasing the anxiety in that sedative nature. That you are not just ever giving Versed like we talked about in the med prep on Tuesday. They are working in different forums and that you need to be giving them together and in tandem so that we're getting that sedative effect, but we're also treating the pain. For Versed, if we have a baby, if we go back up to our question for our weight, of 2.3 kilos. We have the concentration, dosing of 0.1 milligrams per kilo, concentration 1 milligram per ml. You guys will get to that final value of 0.23 mLs, and you will give that over slow IV push over 5 minutes. Never rapid pushing. This is incorrect med math. Along with this, along with answer D as well. Okay. So then midazolam, incompatible with lipids. You are currently, you have TPN and lipids running through a single lumen PIC, assuming additional lines are not able to be obtained. That's the big one there. Which of the following methods for administering this medication is going to be the form of us giving our med? So we were really looking for answer A here, clamping the lipids, flushing that extra port, clearing the line. Then you'll give the Versed, flush 1 ml after the Versed has gone in to clear the line, and then you can unclamp your lipids and restart them. Really just like looking here in that we're not able to obtain any other access. This is a form of giving the meds that we will run here in the NICU if we're limited on access and we have something that's running that's incompatible with each other. As long as it's few and far between, we're not doing it too often. If this is something where, we're having to give a PRN Versed every hour on that, or, every 2 hours, maybe we do talk about getting like a PIV, like, where are we really at with access? Is it impossible to obtain things like that? These other answers to this question, getting another PIC ASAP, inappropriate. We wouldn't get another central line just for this. We would never just switch to SMOF lipids without the baby needing some kind of liver GI support from the SMOF. And lipids is a continuous infusion. You're able to give intermittent meds. That's inappropriate. You wouldn't give them together. You'd need to clear the line. Any questions on any of the Versed or fentanyl questions? Okay. All right. You're admitting a patient with possible seizure activity from the PACU. On admission, you notice a rhythmic movement of the arms, legs, tongue thrusting, and abdominal or an abnormal eye movement. You immediately inform the provider, and when examined, they decide to order a bolus of phenobarb. Your patient is 3.5 kilos. So this required you to get onto Neofax, find the loading dose of phenobarb, which is going to be 20 milligrams per kilo. That's right off Neofax. And then again, off Neofax, finding the ordered concentration of phenobarb is going to be 65 milligrams per ml. And then how to administer phenobarb loading dose. So again, off of Neofax, you'll find that it'll say over 30 minutes, 10 minutes is too short, never rapid push anything. And we do not we do not even give it over slow IV push. It needs to be given over a slow period of time of that 30 minutes on a syringe pump. Then medication calculation here, taking the 3.5 kilos, bringing in that concentration of 20 milligrams per kilo, 65 milligrams per ml for that concentration should give you the final 1.08 mLs. Then number 18, select all that apply. So here we were really just looking for, again, these top 3, respiratory depression, apnea, and hypotension. I feel like most people, I don't remember seeing a ton of people get this wrong. Maybe one just missing apnea along with the respiratory depression. I think, we have tweaked this question in that we don't want it to be a trick question. We just want you guys to know that, like, with respiratory depression, what are we specifically looking for in our patient population? It's going to be that apnea. You're still going to see, abnormal respiratory rhythms, things like that. But we're really looking at that, apnea that is greater than 20 seconds, that we'll see an increase in events like that. Any questions on phenobarb? Okay. You're admitting a transport 2-week-old, 27-week gestational age infant from a neighboring hospital with acute respiratory distress. The infant is admitted on the JET, PIP of 38, PEEP of 13, rate of 300 with an I time of 0.020. FiO2 is at 100%. We're on nitric running at 20 parts per million. You're reviewing your orders and you see that you have IV hydrocortisone, 1 milligram per kilo every 6 hours. The hydrocortisone concentration is 1 milligram per ml, and the patient's weight is 1.2 kilos. So why did the provider order hydrocortisone? We're really just looking for you guys to have that in-depth knowledge that that it's because our babies are cortisone deficient. They are hypotensive. Their adrenal glands and receptors are not working like they should. They need a little help in the beginning. So giving them this hydrocortisone is going to overall help in that cortisol deficiency. We're not doing anything with blood glucose. It has nothing to do with a respiratory support or maturation of lung development, and definitely not strengthening GI motility. For our patient population, how will you administer hydrocort? So really just looking for here that you would give slow IV push over 3 to 5 minutes, 15 and 20, way too long, no rapid IV push, except for those 2 meds we talked about. Any questions on hydrocort? Okay. Okay, so you're taking care of a patient on NIPIV, receiving continuous feeds via transpyloric feeding tube. Patient has an OG tube to vent the stomach and for medications, and then you are planning to go in for your 3 o'clock hands-on care. You look in the MAR and see that you have multiple medications that are due. So we've got morphine, multivite with iron, sodium chloride, and caffeine. So the biggest thing here was well, first let's go over question 21. The resource that you would use to help with any transpyloric feeds and medication administration is going to be the osmolality chart that is in Canvas or Teams now. Which I saw a lot of you guys pull up. It was pulled up on the big screen. A lot of you guys used this in your assessment yesterday. So then you guys had to pick of these medications, which route you would be giving your medications through. So morphine is the major no-no. We would never give that transpylorically. We would only give that gastric. Sodium chloride, that's going to be transpyloric. That's good to give transpyloric. And then caffeine, the same as well. The big one is this multivitamin with iron that people miss. This was the one that we talked about, that the resource we are really working with pharmacy to update because it's a little confusing. The biggest thing we're looking for here is that you guys know that giving multivitamin, especially with iron in it on an empty stomach, is not good for our patient population. They're not getting any nutrition into their stomach. Iron is very harsh on the stomach. The only time that we cannot give iron transpylorically is if we are on EPO, and that is on that resource sheet. Okay. So the answer we were looking for here was that multivitamin with iron will go transpyloric. Any questions on the transpyloric feeds? Oh, and there's one more question. How would you give your medications OD? If you got this wrong, there just wasn't enough detail here, and that we specifically want you mixing the med in the feed. That's really all we're looking for here. Mixing the med in the feed. We do not push meds into a transpyloric tube. It's such a sensitive area. It needs to be mixed in a large volume of milk. And then we also love to see when you guys put the label of the med on the syringe. Okay. 24, you're taking care of a 2-week-old 28-weeker, and they are scheduled for caffeine every 24 hours at 1 a.m. The order states that the dose is 10 milligrams per kilo and the concentration is 20 milligrams per ml. Your infant is 0.85 kilos. How many mLs of caffeine are you going to give? Just with the basic med math steps, you should have ended in a concentration or value of 0.43 mLs. What is the mechanism of action of caffeine? So what we were looking for here, straight off of Neofax, is that it is a CNS stimulant and a cardiac muscle stimulant. Stimulating the lungs for the babies to help breathe easier, just not overall like how it is working in its mechanism of action. It's not decreasing inflammation in the lungs, and it is not a potassium-sparing diuretic. What type of patient is on SMOF lipids? So we were looking for here the GI issues, so any kind of perforation, neck, liver dysfunction helps reduce inflammation. And then 27, so this is bidding at 33 weeker. First blood glucose is 38. Provider orders D10 for a 2.5 kilo baby. What is going to be our dosing? So we're looking for 2 mLs per kilo. Our babies are too sweet. Then doing the med math here to get that final concentrate or that final ml volume of 5 mLs. Sorry, for the recording. Okay. So then how will you administer your D10 bolus? So this is going to be a slow IV push over 1 to 5 minutes, that you're going to actually see that in your MAR when it comes up in an admission. 30 minutes, not doing its due diligence of getting our baby sugar up in an admission situation. No rapid IV push, 60 minutes also, way too long. So then we've got a 40 weeker, 4 kilos, mom, partial abruption. On assessment, baby's pale, low BPs. It's taken multiple attempts to get access. So we're hypotonic here. What are we going to give? We're looking for full normal saline, normal saline bolus. What is the ordered dose that we would do here? We want our babies at the perfect 10 mLs per kilo. And then for that final concentration, we would need for a 4 kilo baby, that's our baby's weight, right? 40 mLs. Okay. Does anybody have questions on any of the questions that were missed? Any of the things that are needed for the med assessment? No? Okay, awesome. Okay. Just sharing here. Okay, Jordan, you can stop the recording.